Welcome to the Joy of Sunflowers podcast. We release podcasts here, in part and in full, on the Joy of Sunflowers website. The Joy of Sunflowers podcast is about sisterhood through infertility and pregnancy loss. We cover a range of topics including fertility, pregnancy after loss, and so much more. I speak with a range of people, including wellness professionals, medical experts, and beautiful mamas. The aim of this podcast is to bring you information and experiences that will validate and equip you for whatever season you find yourself in right now. Hi, Jessica. Welcome to the Joy of Sunflowers. It's so great to have you on here. Please introduce yourself to everyone and let us know about you.
Hi, Ella. Thank you for having me. My name is Jessica. I'm an embryologist in the United States. I've been an embryologist since 2018, and I also recently started an Instagram page and blog called Explaining IVF, where I help educate people about the various aspects of IVF and infertility.
Wonderful. I found a lot of use in your page because I don't know much about IVF, and it's very interesting to actually see some information, and I do think it's really helpful, and the way you do it as well, there's kind of a little bit of humor every now and then as well, which kind of makes it a bit nicer, because obviously going through infertility, going through loss, it's all quite intense. Having a little bit of humor just kind of eases the mind a little bit.
Absolutely. Yes, I did notice there was a big knowledge gap in a lot of the patients that I saw when I was working at the clinics. And so I figured that this was a good way to educate people, because a lot of people were coming into their cycles having questions that really should have been answered before they even started. So I'm hoping that they can use this as a tool to see accurate images and get accurate information before they go into their cycles, to hopefully make better decisions while they're in their cycles. And the humor does help. I wasn't sure at first how people would react to it, because you're right, it is a very sensitive topic, and I really do appreciate the sensitivity of it, but people actually really do enjoy the humor. So I guess, we kind of needed that a little bit.
I think so. And it's just, it can be so awful to be in this space, but then it can also be really beautiful and kind of character building as well. And I think there's a real camaraderie in it. So yeah, comedy just kind of lightens the mood and can just kind of bring you out of that misery headspace and kind of bring you into okay, yes, this is hard, and we're doing this hard thing together. We're not alone in it, and we've got this camaraderie because we've got these comedy joke things that we can all relate to. So
yeah. Absolutely. I have never seen a community as supportive and as informative and knowledgeable as the IVF community, both in the educators, the workers, but also in the people going through it. I mean, there are so many people who are so proud of other people who are doing well when maybe they're not, but it's just so supportive. Or if someone has a question, people are always just so quick to be like, well, let me help you. What can I do to help you? I've been in this situation. Here's something you can do. I've never seen a community as strong and as supportive as this community, and I love it.
It's amazing. When I entered the space, I obviously didn't know it existed until I had a loss, and it was just so amazing to me, because there was just all these amazing women just coming together and really supporting each other. And there's even some men in the space as well that can also be really helpful, just to ease our minds about our own partners, and because sometimes they don't cope or they do things differently. And I think it's just been really fantastic to see that. So first off, just to start off, before we get into the sort of process of IVF, you said about people knowing what to do to sort of set up. So what things would you need to know sort of before you go into the process of IVF?
I think it's important to know the definition of infertility. I think that a lot of people think that, they've been trying for maybe a couple of months and they can't get pregnant. Well, that's not always abnormal. So that doesn't necessarily mean that there's an underlying issue if you've been trying to get pregnant for a few months and it doesn't work. So I think it's good to set your expectations that you might go into a fertility clinic and say, hey, we've been trying for a couple months. And they might just say, keep trying, come back, and we'll work on something. And that doesn't necessarily mean that you're going to jump right into IVF. There could be other options available as well. But the main thing is finding out what is causing you to not be able to get pregnant? Is it something that would require IVF, or is it something that maybe is a hormonal imbalance? Are your tubes blocked, in which case you probably would need IVF? Is there a surgery that you need? What's your diagnosis? So there are a lot of diagnostic tests that you can do that can kind of help decide the best path whenever you are seeking help for infertility. Once you kind of meet that criteria as being infertile, there are some tests such as an HSG, that's a hysterosalpingogram, which is sort of like an x-ray of the uterus and the fallopian tubes. It can tell if there are any blockages. So that can help determine, what course of treatment would be best for you. Or something like a hysteroscopy, which is a scope that kind of goes into the uterus and looks at the lining, because maybe you have a polyp or a fibroid or some scarring. And so then, maybe we need to get that taken care of before we try to get pregnant, because that could be interfering with what's happening. So I think those are a lot of the big things, is knowing exactly what you're going in for. And sometimes people don't know. Sometimes you find out in the process, and unfortunately, some people don't find out at all. It goes into the category of unexplained infertility. But I think that setting yourself up for the expectations, knowing that it could be a prolonged process, it does, just because you go into an IVF clinic just because you go into a fertility clinic does not mean necessarily that you're going to start IVF right away and that you could, perhaps be pregnant within a couple of months. It's a prolonged process.
Yeah, I think like including myself, so many women kind of think, oh, well, if we can't get pregnant, we'll just do IVF. Like we'll just do IVF, and
Yeah.
so like from everything I've seen, it's not like that. It's not that simple. And you don't even think about all the testing to like see if you are infertile or what's going on, because I think a lot of women are just like, no, I'm infertile. It's been so many months. I've tried this long, and I couldn't possibly get pregnant. But yeah, there are odd things that can be happening, within you, and then you do get pregnant, and then you're like, oh.
Right. Right. And sometimes, you think and you're like, you want to get pregnant, you want to do IVF, but then do you want to spend the time, the money, the stress, everything that comes along with IVF when you don't necessarily need it? So it's a double-sided coin. IVF definitely helps people, but it is a process. So, which I know we'll talk about, but you're right. There's a lot more that goes into it than just, I'll go to the doctor and we'll do IVF and everything will be great.
Well, let's go into that process, because obviously I know it's quite a prolonged process. Let's just go through like what's involved in sort of one cycle, one lot of IVF.
Sure. Right. So a basic IVF cycle would actually begin whenever you start your period for the month. So it kind of goes off of your menstrual cycle, but the timing can also be controlled with medications. So the first thing that you will do is something called stimulation. And stimulation just refers to administering medications that do two things. They'll help multiple eggs inside of your ovaries mature, and they'll help ovulation from occurring too soon. So they can control the timing of ovulation. So it's important that the eggs inside of the ovaries mature, because you want to have mature eggs retrieved. If they're not mature, unfortunately, they can't be inseminated. They won't grow into embryos. So it's important that you have hopefully multiple eggs that have matured by the time of the egg retrieval. And that can be monitored with an ultrasound. So they can look at those follicles in the ovaries, and they can measure them on the ultrasound to help estimate if the eggs inside are mature or not. And the second medication, again, it prevents premature ovulation from occurring, because what would happen if ovulation occurred too early is the eggs would not be able to be retrieved. They would be lost.
Wow.
So, yes. So that's the first step. Once your follicles reach a certain level and your hormone levels look okay, your doctor will have you administer what's called a trigger injection. And this will trigger ovulation to occur about maybe 40-ish hours later. So your egg retrieval will actually be scheduled right before ovulation should occur. So again, it prevents those eggs from being ovulated, so they can be retrieved from the ovaries. So that's the first step. And then at a scheduled time, you'll come in and you'll have your egg retrieval. So I know in a lot of cases, this is performed under sedation. And what happens is the doctor will take a needle into each follicle in the ovaries, and they'll use a vacuum pressure to actually aspirate or suck up the fluid from inside of the follicles. And the hope is that in that fluid, there are eggs. So in each follicle, there should be an egg. It's not always the case. There are things called empty follicles, meaning that a follicle grows, but no egg comes out of it for one reason or another. But the hope is that in each of the follicles that are aspirated, there is one mature egg in it. So during the process, the fluid will move through the needle, through a catheter, and into a tube. From there, the tube will go into the IVF lab where an embryologist will look at it under a microscope, and they'll sift through the fluid and they'll find any eggs. So any eggs that are found will get isolated into a separate dish. The rest of the fluid is disposed of. We don't need that anymore. The next step would be to clean the eggs. So if you're doing something called ICSI, which we'll talk about in a minute, the eggs will be cleaned and graded. If not, the eggs will not be cleaned and graded. So one little minor difference between the two processes. But if you're doing ICSI, which a lot of people do, the eggs will be cleaned with an enzyme and they'll be graded to make sure that they're mature. So again, only mature eggs can be properly fertilized. So any eggs that are not mature at the time of ICSI will be discarded. For the other type of insemination, they're not cleaned or graded. So any eggs that are retrieved go into a drop of media with sperm, and they're allowed to co-culture overnight where hopefully insemination occurs. But if you do ICSI on the same day as the retrieval, you'll take a sperm sample, and you'll pick sperm that are normal in appearance and are moving normally, and you'll actually suck those sperm up into a little needle, and you'll put one sperm in each mature egg. And then the following day, whether you're doing ICSI or the standard insemination, you'll check those eggs to see if they properly fertilized. If they did, they get to move on in the process. If not, unfortunately, they're typically discarded.
Oh, wow.
And from there, so from there, you wait a couple of days, and some clinics will look at the embryos over the next couple of days, but most clinics will wait until 5 days after the egg retrieval. So that's called day 5. And that's when a fresh embryo transfer can occur. So that means that an embryo is taken into a catheter and is injected into a woman's uterus using an ultrasound as a guide. The embryos can also be biopsied for pre-implantation genetic testing, or PGT, which is where they look at the chromosomes and the DNA to decide if there are any abnormalities. Or the embryos can be frozen for future use, which is where they're coated in a cryoprotectant and they're placed in liquid nitrogen so that they can be hopefully transferred in a future cycle.
Yeah, we have a lady who's doing that at the moment. She's like trying to save as many eggs as she can. So yeah, that's interesting.
Yeah. And some clinics will culture embryos on up till day 7. Some will culture to day 6. I think most clinics culture to about day 6. And then from there, the embryos, any that continue to grow, can be biopsied and or frozen.
Yeah, that's it's amazing what we can do now, isn't it? Like, gosh, so many things. Are there any factors that kind of change what sort of insemination type you're going through?
There are. So, and that typically deals with the sperm for the most part. So if you have something called male factor infertility, or MFI, that means that you have something that is something male related that is causing the infertility. So an example might be a low sperm count or a low motility. It could be that the sperm, a lot of them are abnormal in appearance. In those cases, it's typically indicated to do ICSI. And it's only because for ICSI, you only need enough good sperm to fertilize each mature egg. For conventional insemination, you need a lot more sperm. So I don't know the exact number, but you need to have a really good concentration of sperm in order for the conventional insemination to be successful. So that would be the number one cause. Another reason might be if you've tried conventional insemination in the past and it failed for any reason, your doctor might say, well, let's try ICSI, because overall ICSI does tend to yield better results, especially when there's any kind of male factor issue.
So is ICSI is where you put it straight into the egg, right?
Right. Yeah. So you'll suck a sperm up into the needle and inject that sperm with that needle into the egg.
Right. And the other one's sort of more natural, like in a tube thing, and then they do their thing, hopefully, and one goes.
Pretty much, yes. They're put together in a drop of media overnight. And yes, we hope that in that time, the sperm will inseminate the eggs. And a lot of times they do, but there are cases where they just don't for one reason or another.
Yeah. I'm guessing there's a price difference, and I'm guessing that's why Yeah.
There's definitely a price difference when it comes to ICSI. I'm sure it's more expensive. I couldn't tell you right off the bat, but I would imagine that it's more expensive, and it does bring more risks because you are doing more manipulation to the eggs. So there's that chance that the eggs could be damaged or that maybe fertilization doesn't occur properly. But overall, it still does tend to yield better results. So a lot of clinics strictly prefer doing ICSI on everyone.
Oh, wow. Okay. A lot of women obviously worry about sort of the pain and the different hormone injections and stuff as well. Does that come in from the beginning?
Yes, so the injections, that will all happen before the egg retrieval even takes place. So whenever the embryos are in the lab, you really won't actually take medications unless you're doing a fresh transfer. So your medications can actually stop before the egg retrieval even occurs. And then you would maybe do medications in a later cycle if you were doing a frozen transfer. But yes, I've heard that they can be quite painful and can leave some bruising. A lot of people have recommended using maybe a numbing spray or a cold or hot pack to kind of help alleviate that pain. And some people also use what are called auto injectors, and they say that helps as well.
I've seen a lot of videos and like pictures of women sort of putting the needles in, and I'm like, gosh, like I do not like needles. So it's sort of I'm like, wow, you're a brave, amazing woman, because I just can't even face needles, like even just getting blood taken. So yeah, to me it's just amazing, and I know that there's so many involved in the IVF process. So we were just talking about sort of the initial kind of like the first process where you're sort of getting the egg and you're going to put the egg with the sperm. So where do we go from there?
Transfer is the ultimate goal. So the ultimate goal is to get those embryos into the uterus to hopefully establish a pregnancy. But there are times when a fresh embryo transfer, a fresh embryo meaning that it has not been frozen. It's just been retrieved a couple of days ago, basically. So that's that is one of the options. Oh, there are reasons why people can't have fresh transfers, and a lot of the times it has to do with the hormone levels. So especially in women who have a lot of eggs that are retrieved, they might have high hormone levels, and so you don't want to do a fresh transfer because it can cause something that's called ovarian hyperstimulation syndrome, and that can be it can be a very serious condition. So if your hormone levels are above a certain amount on the day of your retrieval and you are planning to do a fresh embryo transfer, it will probably be canceled for your safety, and the embryos instead will be frozen, and then in a future cycle they can be thawed and transferred.
Okay, so then you have to wait another cycle. It's not like you can wait a week or so. You have to wait a whole
Right.
cycle, and another cycle is just a month. Is that right?
It usually is. Some clinics do prefer that you take a month off. It gives your body time to rest and reset. And one thing that I'm sure we'll talk about in a little bit is if you do the pre-implantation genetic testing, if you do test for your embryos for any genetic conditions, those results can take 2 to 3 weeks to come back anyway. So you don't necessarily want to start a new cycle until you get those results back. Some people do. So some people will start with the following menstrual cycle, but I know a lot of clinics like to wait to like I said, give your body time to reset before you give yourself more medications, more hormones, and it also gives you time to get those results back.
Yeah, and I'm guessing obviously that will impact your actual results in terms of getting what you want at the end.
Exactly, right. And if you only have one embryo you're able to send off for testing, then you kind of looking at almost like a 50-50 chance, does it come back normal or not? And then why start a cycle if that embryo doesn't come back as normal? Unfortunately, at that point, it wouldn't be transferred.
As we're talking about the embryo stage, how many embryos do you guys like to kind of move forward with?
I think that depends a lot on what the patient's personal goals are. So if a patient wants to have, if they want to have multiple children, then you want to have at least that many embryos, if not more, because as much as you hope that every transfer will be successful, there are reasons why transfers might not work. Or if you're doing the testing and maybe you want to have 2 or 3 kids, you want to hopefully have more embryos than that because they might not all come back as genetically normal. So I would always say whatever your personal goals are, always try to have maybe an extra 2 to 3 embryos. And that's just in case for a failed cycle, maybe they're not genetically normal. And it just gives you, it's called banking, but it gives you embryos basically if you need them in the future.
So moving on from the embryo, so if you can get inseminated, that's if your hormones are either low or like at the right level, and if they're too high, they get frozen. So where do we go from there? So if you were able to be inseminated properly and you have had the embryo placed inside of you, where do we go from there?
So insemination can occur regardless of the hormone levels. So insemination can, so that's pretty much a guarantee. It's the transfer that might be canceled. And the reason is because you have to take more hormones for a transfer to help your uterine lining thicken. And so if you're taking more hormones, but you already have high hormone levels, it can actually cause some damage to your body. So the fresh embryo transfer might be canceled, but insemination will still occur. So you can still inseminate the eggs. You can still let the embryos grow. Just instead of doing a transfer, you would just freeze them instead.
So we're at the stage where we've transferred then. So where do we go from the transfer?
So from the embryo transfer, most clinics will have you wait about 10 to 12 days, and then they'll have you come back into the clinic and you'll do a blood test for what's called a beta HCG. HCG is human chorionic gonadotropin, and that's the hormone that is secreted by cells in the placenta. So if you have a high enough level of HCG in your blood, it means that implantation has occurred, because that's where the placenta comes from, is from the implantation. Those cells, as they begin to divide, that level of HCG starts to rise, and you're hoping to see about a double in the value every 2 days. So every other day, you're hoping to see about a double value for the HCG. But if you come back in 10 to 12 days and that number is really low, maybe say like less than 5, if not more, but we'll say 5 just for reference, that normally means that implantation has not occurred, unfortunately. But from there, if the numbers do come back as positive, the clinic will typically have you come back in about 2 to 3 days, and they'll do a repeat blood test to make sure that the levels are doubling. Some clinics will even have you come in for a third test just to make sure the levels are continuing to double. And then from there, you'll schedule your first ultrasound, assuming that the levels are moving in the appropriate direction. So the ultrasound will then be scheduled, and that's normally, I can't remember exactly when that would occur, but when it does, assuming that everything has gone well, you should be able to see what's called a gestational sac inside of the uterus. And it kind of just looks like a little black hole inside of the uterus. And that's the sac that will become the amniotic sac, where the baby will form and everything. From there, if everything goes well, you'll come back again for another ultrasound. At that point, you'll be able to see a little bit more. You might be able to get a measurement of the fetus at that point. And I don't know exactly when you'll be able to hear the heartbeat, if there is one. It might be at that meeting, at that appointment. If not, they'll have you come back for a third appointment. And normally that's when they can start to hear the heartbeat. Maybe you'll see the little flicker on the screen. After that, and then they'll release you to your
Yes,
OBGYN.
the first one is the sac, and then the second one you might hear the heartbeat. Yeah, because usually when you hear heartbeat, it's like 6 weeks. So
I think so, yes. I hate to say that, because there are like circumstances where even at that time it might be too early. So I don't like to give people false hope. But yes, normally at that point you should be able to hear something. But even if you don't at that point, that doesn't necessarily mean something is wrong. It just means you might have to wait a couple more days.
I really hope you enjoyed the first part of this podcast. If you'd like to listen to the rest, please visit thejoyofsunflowers.com. Please note that all speakers, including experts and professionals, express information, views, and opinions that should not be used to diagnose, treat, cure, or prevent any medical conditions. If you have a medical issue, please consult a qualified professional. Speakers voice their own views, opinions, and conclusions, and they may not reflect the views, opinions, and conclusions of other speakers. Ella Rose, The Joy of Sunflowers, and its sponsors may not endorse all or any of the views, opinions, or conclusions expressed.